Next speaker, approach to the primary angle closure disease, Mithun Thulasidas.
Respected Chair and delegates, good afternoon. So as Dr. Intu ma'am has already spoken about the disease, I'll be actually giving a case-based presentation followed by a brief discussion. So I'll be talking about approach to primary angle closure disease. So case 1 is a 60 years old woman who presented to us with blurring of vision in right eye since 6 months. She had previous episodes of recurrent redness and pain over 2 years. And in right eye, the corrected distance visual acuity was 6/18 with an IOP of 28. Left eye was 6/6 with an IOP of 18. Now, as you can see in the anterior segment picture, right eye, the anterior chamber is shallow with loss of pupillary rough and iris atrophic patches and a subcapsular opacity suggestive of glaucoma flecken, which was correlating with the history with previous episodes of acute angle closure attack. On the other hand, the left eye, the anterior chamber was shallow, rest of the examination was within normal limits. When you do a gonioscopy, you can see occludable ankles in both the eyes with 180-degree peripheral anterior synechiae in the right eye. And when you see the fundus picture, right eye shows a disc with inferior neuroretinal rim thinning and a cup disc ratio of around 0.6 to 0.7, whereas the left eye picture was within normal limits with around 0.3 cupping and healthy neuroretinal rim. When I did a visual fields, again it was correlating with the clinical picture. The right eye showed a superior arcuate scotoma and a nasal stub inferior extending to the arcuate area with a mean deviation of -16 decibels suggestive of advanced glaucoma, and left eye was normal. Diagnosis was clear. It was right eye primary angle closure glaucoma with immature cataract and left eye PACS. So the treatment, I've done a phaco trap with MMC in the right eye as the patient already had an advanced glaucoma with cataract, and left eye we need to definitely do a laser peripheral iodotomy considering the fellow eye status. Case 2 is about a 58-year-old woman who came with headache and eye pain since 3 months episodes associated with nausea sometimes. She was a hypermetrop. Diopy was 24 in right eye and 23 in left eye. Anterior segment examination revealed a grade 1 Van Herrick's and a clear lens. Fundus examination was within normal limits. Again, on gonioscopy, you can see occludable ankles in both eye, which on indentation opened up. So the diagnosis was both eye primary ankle closure because here we have an iridotrabecular contact of more than 180 degrees with a raised intraocular pressure. Again, the treatment plan is nothing less than a laser peripheral iodotomy. Case 3 is 66-year-old woman who came with blurring of vision in both eyes in 3 months. Now she had a few episodes of headache and also diabetic over 5 years. Visual acuity was 6/9. She was also a hypermetrop and the intraocular pressure was 21. Anterior segment examination revealed a grade 2 Van Herrick's and also a significant cataract which is around nucleus sclerosis 2. Fundus examination was within normal limits. Now this is one situation which most of us face in our clinical practice, like you will have both cataract with a suddenly slightly borderline IOP, and yes, obviously when you do a gonioscopy it will be occludable and on indentation it might open up. So in such cases you will be little doubtful whether to dilate the patient initially or whether to go for an iridotomy first, but in my practice, what I usually do is if there are no significant clinical findings in the optic nerve head and when the intraocular pressure is high but no peripheral anterior synechiae on gonioscopy, then you can definitely give it a try by dilating and check the IOP after dilatation also. Now you can see the IOP didn't increase much after dilatation. It was almost in the similar range and the cataract was significant. Such cases you can directly go ahead with phacoemulsification. There is no need of biotreatment with any laser procedure. So a both eye phacoemulsification will give a very good outcome with good visual acuity and a controlled intraocular pressure after the surgery. Now what is the importance of primary angle closure disease? So as per 2020 global estimates, the ratio of PACG to POAG is in the ratio of 1:3, but the ratio of blindness is 1:1. Which means the risk of severe bilateral visual impairment is more with angle closure disease. Now the risk factors have already been explained by Dr. Intu ma'am. So shallow anterior chamber, short axial length, thick iris or lens, emotional stress, nervous individuals, Valsalva, dim light, all these are risk factors. Now there are basically 3 mechanisms One is the pupillary block, which conventionally we know. Second is the lens related. So it is always preferable to check the size of the lens in cases with significant cataract, because sometimes a high lens vault can also predispose to ankle closure. Third one is the plateau iris. Like you can see a double hump sign, which is classical on gonioscopy. One hump is due to the anteriorly positioned ciliary body, and the second one by the equator of the lens. Now, as per International Society of Geographical and Epidemiological Ophthalmology, we have usually 3 subtypes which we usually follow in clinical practice. So an ITC, that is iridotrabecular contact of 180 degree with normal features. Other than that, it is suspect. With an elevated IOP or evidence of PAS, it is angle closure. With optic disc changes, then it is angle closure glaucoma. Diagnosis, definitely when now gonioscopy is the gold standard, definitely an indentation gonioscopy is needed. AIOCMT gives a very objective measurement. It is easily to explain the disease with the patient. UBM to rule out any secondary causes. Water drinking, dark room prone position can be done, but they are not very specific methods to diagnose angle closure. The treatment, laser peripheral iridotomy. Now, when should you do? Like, so after the ZAP trial, it is not necessary that we should do a peripheral iridotomy for all angle closure suspects. So definitely when it is an acute attack, and yes, the patient is a case of primary angle closure glaucoma, or even primary angle closure, you can definitely do iridotomy. Other findings or other conditions where you can do an iridotomy will be the fellow eye of a patient with angle closure glaucoma or angle closure, or with repeated episodes or symptoms, or if the patient cannot follow up, or if the patient understands the risk of progression and asks for a laser peripheral iridotomy. All these scenarios you can definitely go ahead with a peripheral iridotomy. Now, iridoplasty is one thing which we usually do in plateau iris syndrome. That means even after a patent iridotomy, if the angle closure mechanism persists, then you should always consider this diagnosis. The iridoplasty can be easily done using an argon laser. Anti-glaucoma medications and surgery, as we all know. Now, this is a simplified flowchart. When you have a patient with angle closure disease with visually significant cataract, when it is just PACS or PAC, you can just directly go ahead with phaco. Only when it is PACG, and again when it is early glaucoma, sometimes a phaco alone will be beneficial, but definitely when it is moderate or severe, a phaco trap should be considered. So the take-home message is history is very important, because angle closure disease can occur due to drug-induced and other mechanisms also. Gonioscopy is essential, which is the gold standard. Laser peripheral iridotomy is the first treatment of choice. Lens extraction does have a role. I won't say a clear lens extraction, but at least for early cataract or NS1, you can definitely consider lens extraction. Trap should be performed in moderate to advanced cases after proper counseling and taking care of the complications. Thank you.